Welcome back to the Exam Room Nutrition Podcast. I'm your host, Colleen Sloan. I'm a registered dietitian and pediatric PA. I've got a couple funny quotes for you today to introduce our topic. Every time a woman turns 40, a cougar is born. Happy 40th! You now have reached the age where compliments will be followed by, for your age. I'm not 40, I'm 18 years old with 20 years of experience. And lastly, don't think of them as hot flashes. Think of them as your inner child playing with matches. Did you guess what we're discussing today? That's right, women's health. Specifically, we're going to be addressing some common issues women over 40 are faced with. To help equip us with helpful solutions to common nutrition challenges, our guest today is Barbie Bowles. She's a registered dietitian with over 20 years of experience. Her expertise lies in empowering women over 40 to achieve lasting well-being through evidence-based, holistic methods. You can follow her on Instagram at The Cognition Dietitian. Barbie, welcome to the show.
Thank you, Colleen. Thank you for having me. I'm happy to be here.
Well, I'm super excited for this conversation because this is completely opposite of my field in pediatrics, so I'm really looking forward to learning from you. So your expertise lies in women over 40, and they face some very unique challenges when it comes to their health, nutrition, and weight. So let's start out by discussing the common challenges that these women over 40 do struggle with.
Sure. So over 40, the reason that this becomes different, of course, is perimenopause and then ultimately the transition to menopause. This time in our lives is unique in the sense that because of this decline in primarily estrogen, but other hormones as well, progesterone, testosterone, it seems like overnight, although it's not, it seems like almost overnight, we are at increased risk of elevated LDL cholesterol, triglycerides, blood sugar, so insulin resistance, increased intra-abdominal fat because our fat redistributes to the belly area as opposed to staying more in our hips and thighs and bum as it typically does in our 20s and 30s. And high blood pressure. So all of these things, because of this very natural decline in estrogen, become issues where they really weren't before. Even if we've always taken amazing care of ourselves, these things become issues. And so it's sort of a time to re-examine what we're doing, refamiliarize ourselves with our bodies, what our actual needs are, because they definitely do change. We can actually be healthier than we were in our 20s and 30s, but it requires a little more effort, perhaps, and intention than it did before. So these are all things that can come up.
I think that's super encouraging because I know for a lot of women, it is actually quite a struggle and kind of like a sadness to be aging and to get, once you're in your 30, flirty and thriving, then you move on to the 40s and you kind of hit that reality of like, oh man, I'm in the older age range bracket. So I love that you said that because that's really encouraging that we can be at our healthiest despite our aging bodies. So I love that. Now let's talk to the clinicians. And if we've got a patient in their 40s who needs to lose some weight to improve their health, can you educate our clinicians who are listening to appropriately, compassionately discuss this topic of weight loss with the clients and what's the best way to go about that?
Right. So important because so many of my clients, so many of my friends, so many women who are in their 40s, 50s, and even 60s are so dissatisfied with their medical care around this time in their lives because they feel like they're not being heard and they feel like they're not being understood. With these unique challenges, this perimenopause transition, it can feel really awful. For some women, sail right through. Other women literally can barely get out of bed due to a lack of energy. So first and foremost, having a perspective of compassion as opposed to thinking that she should be able to do the same things she did in her 20s is unrealistic and unfair. To really understand this truly is a different phase of life. I actually recommend a book, Dr. Jen Gunter, The Menopause Manifesto. Any clinician who regularly sees women in their 40s and 50s, I highly recommend you pick up this book and read it. It is evidence-based. It's really thorough. It can give you just a really good broad overview of what women are experiencing. It doesn't make you a menopause expert, but it can really help you kind of see maybe stuff you didn't see. Because much like nutrition, they didn't get any training in menopause. And so this can be very new. And when it comes to weight loss, because certainly midlife for men too, it becomes a period of time where weight seems to come on more quickly. This is a very nuanced conversation because there was a huge metabolic rate study that came out in 2021, Ponzer et al., that determined that our metabolic rate does not change very much between the age of 20 and 60. So many clinicians will have seen this study and think, oh, well, this shouldn't be an issue, right? Because our metabolic rate hasn't changed. That was a really super high quality study. That said, I personally, my own research, my own experience, my own professional experience, I think there are things we still don't understand about this period of time in a woman's life. So again, becoming more educated on menopause, listening to your patient. What exactly is going on? Taking a little bit of time and becoming more educated about women in this stage of their lives instead of just saying, eat less, exercise more. Because additionally, for anyone who wants to lose weight, each person is physiologically unique. What works for one is not necessarily going to work for another. So we have to be really focused on the individual and what they have going on, what unique challenges they have. And that's not going to be the same for any two people. And if that's not something you have time for or the expertise in, have a registered dietitian standing by. That would be my recommendation.
Yeah, I definitely agree because there isn't that time in the clinic visit to really get into the nitty gritty of what they're eating, what their daily habits look like. But is there any kind of quick recommendation to at least jumpstart a patient on the right path to healthy eating? Should we be recommending 5 fruits and vegetables a day? Should we be recommending more sources of animal protein versus non-animal sources of protein? Are there any kind of quick tips that the clinician might be able to provide to the patient that would be helpful?
Because I am very partial to brain health, because I think that when you are targeting the brain, you are targeting everything. You're targeting your blood pressure, your cholesterol, your insulin sensitivity, your weight, and your overall health. I am a really big fan at the moment. Research is always changing, but I'm a really big fan of the MIND diet, MIND, Mediterranean Interventions for Neurodegenerative Delay. This is a research study that came out of Rush University, Chicago in 2015, and it's evolved over time since then because there have been research studies based on it. So I think that's a good place to start. If all you've got is check this out, please stop broadly recommending keto and intermittent fasting. Please, let's stop doing that. This would be a much better approach. And then that person can become more educated in that and figure out, how does this apply? What can I include? Because that's the other thing. What we really want to be encouraging is not exclusion necessarily, but inclusion of foods that we know to be particularly beneficial for metabolic health. That is much easier for a person to implement than cut out dairy, cut out gluten, cut out grains, cut out, carbs, whatever, all of which is terrible advice, by the way, if the person isn't sensitive to those foods. I think if you can only make one 5-minute recommendation, guide them towards the MIND diet, and I'll give you sources.
That's perfect. So I'm going to go ahead and link those details below. So I would absolutely recommend that you check that out so you can educate yourself and you can provide those sources for your patients as well. So you touched a little bit on intermittent fasting, and this actually comes up quite a lot in women over 40. And this is just from my friends and family members. I hear a lot of them say, well, I just can't lose weight if I eat more than 1,000 calories, or I just can only eat dinner, so I'm intermittent fasting. My question to you is, why is this harmful potentially and inappropriate type of, dieting pattern for this population of women?
Well, I would say not just for this population of women, but for anyone. First and foremost, when we say intermittent fasting, this can mean a lot of things. There are a lot of different approaches to intermittent fasting. Do you mean 16-8? Do you mean in 4-hour eating window? Do you mean eating normally 3 days a week and starving yourself 4 days a week? I mean, it all depends on what you're talking about. For some people, it is very manageable. Their personalities appreciate this sort of structure of eating within a certain window. That's totally appropriate then. If it's stressing you out in any way to try to confine your calories to an 8-hour window, or whatever hour window for fat loss. Now, there may be other metabolic benefits, but nothing is completely clear yet. So it would not be enough for me to make a recommendation based on metabolic health. But for fat loss alone, intermittent fasting is no more effective than calorie restriction. So if you are someone who just like really stressed out by the idea of intermittent fasting, you don't need to do that in order to have the same fat loss results. The other thing about intermittent fasting that is almost never talked about, and I really don't understand why, is let's just say the average person has an 8-hour eating window and it's usually 12 p.m. to 8 p.m. This is a bit backwards because we are more insulin sensitive in the morning hours. So if somebody is going to intermittent fast, I would recommend shifting that window to include a morning meal and having an earlier dinner. The other thing about intermittent fasting that is just super clear from research, when people are intermittent fasting, essentially all they're doing is cutting out a meal. They're not eating the same number of calories they were eating before, just in a smaller window. If they were, it would not be effective for fat loss. If a woman is saying, I can't eat more than 1,000 calories a day or I gain weight, I highly recommend she track her calories for, I don't know, 2 weeks maybe, because there's no way she's consuming 1,000 calories a day. It's not what's actually happening. I know we can feel like that's what we're doing, especially if we're guesstimating, but what's required for fat loss is a calorie deficit. Period. The carbohydrate insulin model has been debunked. Reverse dieting has been debunked. It is all about creating a calorie deficit. 1,000 calories a day is barely enough. That's not even enough for a 12-year-old.
Right.
So, I doubt seriously, and I'm not trying to offend anyone or undermine how they're feeling, but I've been doing this a really long time. And if you're eating 1,000 calories a day and not losing weight, something is very seriously wrong. It's not just that you're having trouble losing fat or your hormones. So I would recommend, if you're really confused, like I feel like I'm barely eating, but I'm not losing fat, try tracking your calories just for a period of time. I don't love that as a long-term strategy, but it can be a really good short-term educational tool. The key to tracking is to be 100% accurate. So if you're doing what I call pop-ins and drive-bys, where you're reaching into the fridge and grabbing a handful of grapes or into the pantry and a handful of chips, that has to go into your tracking. And I guarantee you're consuming more calories than you think you are. And you just need to create a deficit. The problem is creating a deficit you can be consistent about, because you have to love it in order for it to be sustainable. Does that make sense?
Excellent. Yes, that was a beautiful explanation. Just to close out the conversation on intermittent fasting, because you mentioned tracking, and I know this does come up a lot with clinicians and their patients. Do you recommend an app for them to do this? Is there something that might make it a little bit easier for patients to do this?
The way I feel about tracking apps, because there are a lot of them, first of all, it should be free. I mean, this should not be something people are paying for, because there are certainly free versions that are just as good. I personally like the Lose It app only because it is no bells and whistles, super straightforward, really easy. They've got a good database. You can put in your own recipes. I like it because it's just no fuss, no muss, no bother. A lot of people like MyFitnessPal. I think it depends on you and what appeals to your brain in terms of the interface. I don't really think it matters. I think they're kind of all the same, with the caveat that none of them are completely accurate. So, the way we measure calories, this, the way we measure calories is just not on the nose. So what I like to do is use it as sort of a guideline, not like, oh, let's try to get within 5 calories of your, allotted amount. I mean, like, it's just about seeing a pattern over time. It's not about trying to be very exact. I also think it's really helpful because you want to make sure you're getting enough protein, and it will tell you your macronutrient breakdown. If someone needs to lose fat in order to benefit their metabolic health, rather than talking too much about fat loss, encourage these people to gain muscle. With a case that is really kind of challenging, like they're really challenged by the idea of fat loss, focus more on muscle mass. Completely flip the script, start strength training, and start eating enough protein. That is really important.
That's excellent. So just to recap, if you've got a patient who comes to you and says, hey, I'm only eating 1,000 calories, 800 calories, and I'm still not losing weight, I highly recommend what Barbie had suggested. let's track the calories, and it doesn't need to be long-term. We're just doing this for 2 weeks to really see how many calories, how much protein, fiber is this individual truly eating? And then you can go from there before you even start recommending, okay, let's cut carbs, let's cut dairy, really get to see how many calories they are truly eating. I think that's a really good place to start when you're seeing patients in the clinic. Let's move on to some specific things that I know comes up a lot with these women is maybe we've done a, complete metabolic panel, we've done some labs and everything came out normal, which is the most frustrating thing I think sometimes to hear. Sometimes you subconsciously want something to be wrong with you so you can work on that and fix that. But, you get hey, your labs are normal. Now what? So what do we do in that case if all the labs are normal, but we still have this woman standing in front of us who's looking for our help?
Yeah, this is incredibly common, right? And, even if a few things are abnormal, like elevated LDL cholesterol or even blood pressure or HbA1c, that may not necessarily be what's making them not feel good. We don't actually feel most of that most of the time, right? First of all, I really recommend everybody get B12, vitamin D, and iron checked annually. I know that a lot of clinicians will think that's a little bit extra. I don't think so, especially for women over 40. I also think fasting insulin is important because it is a precursor to, our HbA1c getting wonky. We will see that first. So I think that should sort of be a regular part of things. Again, maybe or maybe not something someone would actually feel. Certainly vitamin deficiencies someone is going to feel. So I think that's important. I also think high sensitivity C-reactive protein is important, just to see, is the needle moving on inflammation in a way that we don't like? And again, this comes down to time, but having a conversation about, are you sleeping? Are you eating breakfast? Are you starving yourself all day and eating a lot at night? Are you scrolling until midnight? Do you have a lot of stress in your life? How are your work boundaries? How are your personal boundaries? I know you probably don't want to get too much into their personal relationships, but ask them, maybe just more of a prompt to consider what might be happening in their personal lives that may be causing more stress than they realize. Again, this is where having a little handful of therapists that you refer out to, much like earlier with nutrition, with dietitians. This is where, you might want to consider seeing this therapist about just, a couple sessions, kind of knock some things out, see if maybe stress is causing some problems. Sleep is certainly an issue for midlife women. It's just part of it. And if we are not sleeping well, we are simply not going to function well. I know plenty of women who say, I'm sleeping 4 hours, I'm all good. No, you're not. No, you're not. Not only are you not functioning well, and this is an issue for clinicians too, because of their hours and being on call and so on, this really impacts the structure and the communication within your brain. So sleep deprivation is a risk factor for dementia and type 2 diabetes. So sleep, exercise, managing stress. Are these things in good working order? Are you exercising? Are you moving your body, or are you sedentary? Because the human body is designed to require movement. If we're not moving our bodies, and this doesn't mean crushing it at CrossFit, it just means taking a walk or, just doing some stretching even if lab work looks good and someone still feels pretty crappy. Additionally, maybe it's time to have a conversation with somebody who is an expert in hormone replacement therapy and see if that's appropriate.
Awesome. Yeah, I remember in my training for PA school, they would always tell us to, don't just look at the numbers, look at the patient sitting in front of you. Especially, if you have normal numbers, yes, but sometimes you'd have a really off abnormal number. And instead of panicking and freaking out about it, the patient's sitting there totally fine and it could be likely totally fine. So I love that, looking beyond the numbers and focusing and asking about those few things that you said. So exercise, sleep, and managing stress, 3 really important things that we need to be asking our women about. All right, let's move on because you mentioned this briefly. I wanted to linger a little bit more regarding hormone replacement therapy. Talk to us about this. When should it be something that should be brought up to start? How can we educate our patients about this a little bit more?
Sure. So again, when a woman begins perimenopause is going to be unique to her. It's not as uncommon as one might think for it to start around 37, 38. If a woman is having hot flashes, vaginal dryness, fatigue, trouble sleeping, don't dismiss her as too young for perimenopause. That happens to a lot of women. And in fact, they would start benefiting from hormone replacement therapy. So never dismiss it as absolutely not possible because a woman is too young. That said, let's say a woman is more in her early 40s, certainly late 40s. Again, hot flashes and vaginal dryness would be the two things that hormone replacement therapy is really, it's what it is absolutely effective for. Okay. Everything else, the energy, the sleep, potential heart benefits, potential dementia benefits, it's kind of, we don't totally know. Oh, definitely for bone health as well. So there's that. But, start having this conversation. Ask the question, do you think it could be perimenopause? How's your menstruation been? Has it gotten a little weird? Are you having hot flashes? Are you having trouble sleeping? How is your mood? And then maybe if you are not well versed in hormone replacement therapy, it would be time to find another expert, whether that's an OBGYN or just another doctor or nurse practitioner who has that expertise. It would be time for your patient to go have a conversation with them about it. And just in case you yourself or, your colleagues are, quote, anti-HRT, the issues with hormone replacement therapy and risk have been greatly overstated. And much of that has been sort of revised. I would highly recommend reading the latest North American Menopause Society position statement on hormone replacement therapy, because that is where all the newest information is. We don't want to go based off of what we were thinking from that 2001 study that scared everybody. So time to update your thinking so that you can be treating your women as well as you possibly can.
Yeah, I cannot agree more how important it is to stay up to date on medicine. 2001 to 2023 is a very large gap in science and in the advancement of medicine. So we'll go ahead and also link that below too if you want to get yourself a little bit more educated and stay up to date. So let's close out with any supplements that you might recommend that we as clinicians can encourage our patients to start or to consider.
I tend to be very judicious with supplements. That said, they're very appropriate in some cases. I personally think it's a good idea to test vitamin D and B12 before they're supplemented. That said, most people are really all right with B12, but it can start to become an issue in midlife. Vitamin D, I can't remember the last time I saw somebody who was sufficient in vitamin D. So that's kind of a given, but it also helps to test because someone could be seriously deficient. I saw someone with a level of 5 yesterday.
Wow.
So, 1,000 units isn't going to do it. So B vitamins, I should say, B complex, really important. Vitamin D, but use your best judgment about how much a person needs based on testing their levels. And omega-3s, EPA and DHA, I should say, not very easy to get enough of from food. So in general, I do recommend that, but staying conservative around 1,000 milligrams or a gram a day. Certainly more has been demonstrated to have really nice effects on reducing inflammation, lowering triglycerides in studies, but we have to be careful about bleeding issues. In addition to that, you can actually get your omega-3 levels tested through a company called Omega Quant. It's called the Omega-3 Index, and they send you a little kit. You put 3 drops of blood on a card, send it back, and in 2 weeks, they give you this full report of your omega-3 index. It's a good test if you feel like that's something that would be appropriate. But B vitamins, vitamin D, and omega-3s, fiber, make sure your people are getting enough fiber. And if they're not supplementing with fiber, if they're really just not hitting it with the fruits and vegetables, a fiber supplement would be a good idea.
And for fiber, like just anything that they can purchase from on the shelves, like Metamucil or any of the psyllium fiber would be sufficient?
Yeah, I'm a big fan of psyllium. There's some good research on psyllium, but just also anecdotally myself, my clients, psyllium seems to get things moving really nicely.
Barbie, I love that you brought so much science and so many resources that our clinicians can link to and look up and educate themselves later. So I'm so grateful for the gift of your time and for you providing this valuable resource to us as clinicians so that we can properly care for these women over 40 who have so many unique challenges and that do require so much compassion to, just to help them to feel at their best. So is there anything that we've missed or anything that you would like to close with that you think it's important for the clinicians to know?
I just want to reiterate that, Perimenopause, menopause, it's not a disease. It's not an illness.
Right.
It's a phase. It's much like puberty or pregnancy. I mean, it's very normal, but it presents different needs. And so just for it to be viewed in that way, it's very real that we have different needs, but it should not be viewed as something really unfortunate or tragic or, like a disease state. But just to spend a little extra few hours this week, maybe reading a book, educating yourself, looking at NAMs, and just getting a little more current on what women really need. Your patients will thank you, I promise you, because I hear the other end of this.
Yep, exactly. And that's why we're doing this. Thank you guys so much for tuning into the Exam Room Nutrition Podcast. If you have a question that you would like to submit to Barbie, you can absolutely follow her on Instagram at The Cognition Dietitian. You can find her online at www.barbiebowles.com. I'm going to link all of the resources that Barbie had suggested down in the show notes below so that you can take a look at those later on. Barbie, thank you again for being with us. It's been a pleasure.
Thank you so much, Colleen. And thank you, everyone listening.
All right, guys, now it's time for my nutrition notes. In this section, I will leave you with a nutrition tip, an interesting quote, or a fascinating case that I think might add value to your day. Now, in keeping with the theme of the day of quotes, as I opened this episode with several funny quotes, I will leave you with another quote. And I hope this quote encourages you to continue to provide compassionate care to your patients. I know how exhausting practicing medicine is, and that you can really feel weighed down at the end of the day. And especially now with this podcast, I'm encouraging you to discuss nutrition, which you think, oh my goodness, I might not even have any time to do this. But I'm here to tell you that you can do it. So the quote is from Wes Fisher. He is a physician. It says, "As a clinician, people will trust you, confide in you, and appreciate your efforts. You can do amazing things for people if you don't let the system get you down." I hope that encourages you today and you found some value in today's episode. If you haven't already, please leave me a 5-star review in your favorite podcast app or subscribe to my YouTube channel. This can help other people find this podcast, and I would greatly appreciate your support. Well, that's it for today, guys. So let's continue to make our patients healthier, one exam room at a time. I'll see you next time.